Have you ever wondered about the difference between amphetamine and methamphetamine and their distinct impacts in the body? Well, if you have, hold on tight because we're about to deep dive into the specifics that make these two substances different and complex. So let me take you into the world of amphetamine and methamphetamine. Hi everyone, welcome to Psychiatry Simplified. I'm Rege, consultant psychiatrist. This is the channel where we break down complex topics in psychiatry into easy to understand concepts. If that's your thing, don't forget to subscribe and hit the notifications bell to stay in touch with all the latest releases.
So let's get started.
Now, oral methamphetamine, also known as Desoxyn, is available in the US for the treatment of ADHD in children above the age of 6. It's also available for the treatment of obesity. Amphetamines, on the other hand, are both well-known and commonly utilized in the treatment of ADHD in children and adolescents and adults. They come in various forms, as we know. You might have heard of Adderall, Dexedrine, which is dexamphetamine, and longer acting versions. So in today's video, we'll be discussing the 5 most important differences between amphetamine and methamphetamine. So let's dive straight in. All right, before we begin, here's a mind-blowing fact. If you're in your 40s, you've likely used methamphetamine without even realizing it. That's right. Prior to 1994, Vicks vapor inhalers contained a form of methamphetamine which was lev-methamphetamine. Imagine that. So, the first difference, the structure. Methamphetamine has 2 stereoisomers. These are sort of mirror images. Methamphetamine comes in 2 forms, which is the S-methamphetamine and R-methamphetamine. The S isomer packs a more potent punch than its counterpart, the R isomer. So the R stereoisomer is the same as lev-methamphetamine, which was there prior to 1994 in the Vicks vapor inhalers. Amphetamine, on the other hand, consists of 2 enantiomers, D-amphetamine and L-amphetamine. So we know dexamphetamine or Dexedrine is available for treatment. Structurally, the main thing that makes methamphetamine different from amphetamine is that the S-amphetamine carries a methyl substituent, and this changes the entire pharmacology of methamphetamine. The second difference is the effect on the dopamine transporters. You see, methamphetamine takes the crown when it comes to the effect on dopamine levels. Studies show that it can boost dopamine levels by an astounding 2,600%, and it does this by stimulating the release of dopamine rather than simply blocking it. So you get a significant effect on dopamine release. Now, studies have shown that methamphetamine released 5 times more dopamine than amphetamine did at physiological membrane potentials. And this significant dopamine release contributes to the euphoric and addictive properties of methamphetamine compared to amphetamine. Too much dopamine can be harmful to the brain. The third difference is in route of administration. Methamphetamine can be ingested orally, snorted, injected, or even smoked, which often makes it a versatile and widely abused substance. Amphetamine, on the other hand, is taken orally or intranasally, and of course may be misused intravenously. However, unlike the hydrochloride salt of methamphetamine, amphetamine sulfate is insufficiently volatile to be smoked. And one of the reasons for the addictive potential of methamphetamine is this smokable form of methamphetamine that results in a very rapid and intense high. This does not happen with amphetamine, as amphetamine sulfate is insufficiently volatile to be smoked. The other aspect is that methamphetamine is highly lipophilic. We'll talk about that in just a bit when we come to the absorption. But because it's lipophilic, it passes through the blood-brain barrier very, very easily for its rapid effects. It's fascinating how just these subtle differences in the route of administration can make such a big difference to the ultimate impact on the brain. The fourth difference, the speed of action and bioavailability. Now, this speed of action and bioavailability is closely linked to the benefit and the risk balance, where amphetamine is a safer agent than methamphetamine. You see, methamphetamine's lipophilicity, which is the ability to dissolve in the fat and lipids, the adipose tissue of the body, gives it an advantage in terms of its bioavailability and speed of action. It allows methamphetamine to cross the blood-brain barrier much quicker than other stimulants, leading to a rapid and intense effect on the brain, which is linked to the euphoric property of methamphetamine. Now, when it comes to the onset and peak action, here's where the two substances differ. Methamphetamine typically kicks in about 5 to 30 minutes after ingestion, with its peak effects occurring about 2 to 4 hours later. Fascinatingly, a 30 milligram dose of methamphetamine may last up to 8 hours, making it a potent and long-lasting stimulant. On the other hand, when it comes to amphetamine takes slightly longer to kick in, onset ranging from approximately 30 to 60 minutes after consumption. And while it may not act as quickly as some of the other stimulants, it's important to remember that amphetamine-like substances all have significant effects on the brain. And this rapid action is something that we don't necessarily want. So to give you a further example of the difference, take Adderall XR. The dose of Adderall XR, which is mixed amphetamine salts used in the treatment of ADHD. Now, the common doses range from 5 milligrams to 30 milligrams. Now, higher doses are mentioned in literature, but this is sort of the general doses. Now, this can result in a peak plasma dexamphetamine or D-amphetamine level of approximately 10 to 110 nanograms per milliliter. In comparison, a single dose of crystal meth, which is sufficient to cause a significant rush, has been reported to be about 40 to 60 milligrams. But here's the issue. Real-life study of unsupervised recreational methamphetamine users as part of a police investigation showed that blood levels range from 15 nanograms to 1,600 nanograms per milliliter, with a median of 190 nanograms per milliliter. That is a significant level. And evidence also shows that the doses used by methamphetamine users over time tend to increase, and they may be binging type use that results in much higher levels of methamphetamine in the blood. Interestingly, the speed of onset can vary depending on the form in which these substances are used. For example, medically screened patients might experience a slower onset with oral forms of amphetamines, particularly those with cardiac abnormalities. On the other hand, unsupervised crystal meth users may opt for the smokable form of methamphetamine, which can provide a very rapid, fast onset within seconds to minutes. The differences in speed of action and bioavailability between methamphetamine and amphetamine has important consequences on the harm aspect related to the brain and the rest of the body as well. So that takes us to the fifth point, which is the pharmacological impact of methamphetamine and amphetamine on the brain. Now, both amphetamine and methamphetamine affect the metabolism of dopamine, noradrenaline, serotonin, and they increase the levels of all three neurotransmitters. However, one key difference lies in how methamphetamine generates way more dopamine efflux, the release, and higher calcium release compared to amphetamine. The difference could explain why methamphetamine firstly is more euphoric and addictive because of the dopamine efflux, but the ability of methamphetamine to release dopamine, serotonin, and inhibit MAO-A oxidase activity leads to what we call oxidation of dopamine and serotonin. Now, methamphetamine-induced neural damage is mediated by the production of free radicals that occur after there is significant calcium efflux, dopamine efflux, serotonin efflux. The point is that too much of these neurotransmitters can result in a significant oxidative stress, the release of free radicals, which are neurotoxic. Furthermore, what happens is when there is excess release of these neurotransmitters, essentially these neurotransmitters are depleted. So longer-term use or severe use of this substance, methamphetamine, results in longer-term dopamine and serotonin depletion in the striatum, which is the movement area of the brain. And sometimes we see this in clinical practice where they may be tremors, for example, or cogwheel rigidity, Parkinsonian type side effects because of methamphetamine use, and may also affect cognitive function. And of course, we know psychosis due to the dopamine hypothesis of psychosis can be significantly triggered off as well. Now, we do know that because of the significant dopaminergic, serotonergic, noradrenergic release, there are peripheral effects on the beta receptors and the alpha receptors that can result in cardiac effects, can result in vasoconstriction of the vessels, both peripherally and also cerebrally. And this results in, of course, significant impact on oral health, skin health, cardiovascular health, etc. Now, amphetamine compared to methamphetamine is, of course, safer because it does not have that significant amount of release of these neurotransmitters. However, misuse of amphetamine can result in a very similar picture. So evidence does show that amphetamine use can result in the depletion of dopamine, particularly what we call striatal dopamine transporters, over the long term. Now, this can be exacerbated in individuals who misuse it, but also one of the things that's relevant to psychiatric practice is that we prefer to prescribe the longer acting version so that we do not have these peaks and troughs, the pulsatile release of dopamine that is more linked to the euphoric, the addiction aspects. We prefer the tonic dopamine release, which is essential for reward learning, concentration, and movement. So to recap, we can see that amphetamine and methamphetamine are far from being just simple substances. They have significant effects on the brain, the specific neurotransmitters, the transporter parts of the brain, and this can have a significant impact overall on brain function. Understanding these nuances is crucial for clinical professionals, but also for individuals that are using these substances. If you found this video useful, please don't forget to give us a thumbs up and subscribe to our channel for more simplified psychiatry content. If you've got any questions, please feel free to ask them in the comment section. And of course, let us know what other videos you'd like. I look forward to seeing you in another video soon. Until then, stay fascinated. Bye-bye.